All right, well, let's get started. Welcome to all the participants and especially the panelists. A warm welcome from Geneva, Switzerland and the United Nations Institute for Training and Research and the Global Surgery Foundation. We're very happy to be hosting this webinar today for EBRS Online and very pleased with this collaboration in trying to get this information out, not just around Canada, which is a very special place for me as a Canadian surgeon, but around the world. So we're very happy to be working to that end. So without any further ado, I'd like to introduce our two moderators, Dr. Elijah Dixon and Dr. Indranil Datta from the University of Calgary, and turn the floor over to them to introduce the panelists, and I'll say a few words at the very end. So thank you again, Elijah and Neil, for moderating, and the floor is yours. Thank you very much.
Thanks, Jeff. So I'm Elijah Dixon, and I just want to say a few words about EBRS, and then I'll hand it over to Dr. Datta, who's going to introduce the panelists and get things rolling. The structure this morning will be the typical format that evidence-based reviews in surgery does when they do a virtual journal club. There'll be a methodologic review of the article, so sort of looking at the science of the article. And then there's two clinical experts that will comment on the context of the paper and the significance of the findings of the paper. And then we'll open it up for discussion, and anyone that wants to ask a question, we would encourage you to do that through the Q&A, and myself and Dr. Datta will field those questions and pose them to the panelists and hopefully get a good discussion going here. I want to thank Jeff Ibbotson and Julia Genth for making this happen and for collaborating with us. So we're very excited at EBRS to be collaborating with Unitar. This is the second time we've done this, and the first one was great, and we're looking forward to many more. And this is a great opportunity for people from all over the world to get together and learn critical appraisal skills and to review articles together. So we're very excited about it. Evidence-based reviews in surgery has been around for a long time. It was the brainchild and created by Rob McLeod, who's, as many of you would know, an iconic surgeon at the University of Toronto, and she's put it together and really built it up, and along with Mark McKenzie did an amazing amount of work to get EBRS in its current state. She's entrusted EBRS to myself and Carl Brown, who are the co-directors of it now, and have others that are on the executive, Dr. Datta, Dr. Ball, Dr. Park, who are also helping to run EBRS. You can find us at ebrs.online, so please find us and look us up and join. We have one of these, a new article every month, so we would love to have you visit our site. And then just sort of as a final note before we get started, there is the opportunity to get CME points here today. So at the end of the discussion, Dr. Ibbotson's going to put up a link that you can go to get CME points for participation today. So please log on and do that at the end of the discussion, along with a brief survey to let us know what you thought of things. So I'm going to hand it over now to Dr. Datta, who is one of my partners here in Calgary, and he's going to take it to the introduction of the panelists.
Thanks, Elijah. We're really excited today about our topic. We're, of course, talking about the optimal treatment of primary spontaneous pneumothorax. Is intervention really required in this situation? We have three great panelists. I'd like to introduce Dr. Morgan Schellenberg. She's an assistant professor of clinical surgery and acute care surgery at USC Medical Center and the Keck School of Medicine. Dr. Biniam Kidani, who's a thoracic surgeon at the Max Ratty School of Medicine at the University of Manitoba. He's also has a master's in clinical epidemiology, and he'll be doing our methodologic review. And Dr. Chad Ball, who's a colleague and partner of ours here in Calgary, who's an extremely well-known trauma surgeon and a member of the Cummings School of Medicine here at the University of Calgary. I think before we start with Dr. Kadani's methodologic review, Julia, if you could put up our two questions and we'll survey our audience. Julia, is it possible to see the results of those questions? Excellent. So it looks like we have a nice broad range of people from North America, Europe, Asia, and Africa, and also we have general surgeons, thoracic surgeons, and also some internal medicine physicians as well. Excellent. So I'll hand it over now to Dr. Kadani, who will start our methodologic review.
Thank you very much for this privilege of doing this review and participating on this panel. So if we just go to the next slide. Next slide, please. Thank you very much. I do want to acknowledge my co-reviewer on this, an excellent thoracic surgery fellow, Dr. Andrew Giles. And if any of the 21 thoracic surgeons are looking for anybody for a job, this is an excellent, excellent candidate. No conflicts of interest otherwise. Next slide, please. So the background is that primary spontaneous pneumothorax is an atraumatic disease with no underlying primary lung disease. So essentially, it is a situation that occurs when there is no primary traumatic event and there is no COPD or other underlying lung disease that leads to this. In general, the management of this small pneumothoraces has been observation and outpatient follow-up. If you click the next button, there's an animation that will encircle the and the next one. So in general, and the next one as well. So in general, the moderate to large pneumothoraces in general have been defined as anything greater than 2 or 3 centimeters or any lateral chest wall dehiscence or separation from the lateral chest wall. And in general, the existing guidelines recommend some sort of intervention, so either aspiration or catheter insertion. Next slide, please. So the study objective or question is conservative treatment or no intervention non-inferior to small chest tube insertion in the management of patients with first episode of primary spontaneous pneumothorax? Next slide, please. This is a multi-center study. So in fact, there are 39 urban and rural hospitals, and this was framed or set up as a non-inferiority trial in New Zealand and Australia. It is predominantly emergency medicine practitioners. And so unfortunately, we have no emergency medicine physicians on our discussion today or in our audience, and nobody from New Zealand or Australia. So I hope people join from there and from those fields. The age range was from 14 to 50, and they actually specifically mandated that it had to be moderate to large pneumothorax. So it had to be more than 32% by size using the Collins method. So the X-ray that you see here is a description of how the Collins method is calculated. So it has, so this particular example, the actual pneumothorax size is 63.6%, and thus it would have been eligible for this trial. There are many inclusions, including obviously tension pneumothorax at presentation. It was a one-to-one stratified real-time web-based randomization, and it was an adaptive biased coin or urn technique. And essentially, it was meant to try to maintain prognostic balance and randomization across many sites. The more sites you increase, there's always a risk that your randomization will be lost. And so this is a method to try to maintain stratified randomization. Then they chose a non-inferiority margin of 9%, and they made an assumption that there would be 99% resolution at 8 weeks if you use the chest tube. They performed chest x-rays at 2, 4, and 8 weeks until resolution. Next slide, please. Their primary outcome was full lung expansion on a chest radiograph at 8 weeks, and their primary analysis was intention to treat. Their secondary outcomes was the same outcome, but with a per protocol analysis, which is very important when you're doing a non-inferiority trial. There were a whole bunch of secondary outcomes, including adverse events, length of stay, patient satisfaction, etc. Their primary analysis was a logistic regression of complete cases at 8 weeks. So they had some certain assumptions about loss to follow-up, and we'll get to that in a moment. If you just go to the next slide. So essentially, if you look at this table here, if you look at the primary outcome, so the primary outcomes assumption that was that if there were people that did not show up for their 8-week chest X-ray, that they were counted as missing. And so looking at these patients, the resolution of the pneumothorax was 98.5% with a chest tube insertion and was 94.4% with no chest tube insertion. And so the risk difference is a 4% difference, and thus this would be considered non-inferior because the non-inferiority margin was 9%. So we're willing to tolerate a 9% reduction in effectiveness or efficacy of resolution. In the first pre-specified sensitivity analysis, they identified that people that had that were missing at 56 days, but were captured within 63 days would be able to be counted, but anybody that was missing after the 63rd day would be considered as missing. And again, in this particular sensitivity analysis, it replicated the primary analysis. And the second sensitivity analysis was that anybody that was not captured at that 56-day mark or the 8-week mark would be considered a failure of resolution. And thus, in this particular sensitivity analysis, the resolution was 93.5% with the tube, and the resolution with no tube was 82.5%. And the difference was 11%, which was outside of the non-inferiority margin, and thus it would be considered to be inferior, or conservative management would be considered to be inferior. So this can be something to discuss in later discussions, but I'll move on for now. About 15.4% of people in the conservative management group crossed over to the tube insertion group. This is mostly due to concerns of disease progression. And it should be noted that those who crossed over had more adverse events than those with upfront tube insertion. So that's an important point for interpretation of these results. With tube insertion, there was the expected result that there was a faster resolution. If you get a tube in, your pneumothorax resolves faster. But there was an unexpected result that there was an increased risk of recurrence with chest tube insertion, which is unexpected, and again, I think bears discussion. And in general, patients are satisfied with both approaches. Next slide, please. So one major thing to think about is that tension pneumothorax is a rare event, but it's potentially deadly. In the tube insertion group, there were 2 tension pneumothoraces, and you can see it in this table here. One was due to kinking, and this was fixed by unkinking the tube. And the other was found 4 days later after the tube was removed and the patient had been sent home. In the conservative group, there was one tension pneumothorax that occurred about a day or so after discharge home, and all of these tension pneumothoraces resolved with tube insertion. Many adverse events are related to tube management issues. You can see here there's 6 surgical emphysemas, there's skin infection, foreign body, chest wall. Essentially, it's a retained suture, and equipment disconnection. One has to wonder about the effect of differential application of co-intervention. So one of the main ways to maintain prognostic balance is that your groups must get the same co-interventions. I mean, there must not be a differential application between groups of co-interventions. There are a lot of, chest tube management is a co-intervention. Pain management is a co-intervention. And so when you have 39 sites and there's 316 patients, that's an average of 8 patients treated per site. And so there's pros and cons in terms of the ability to maintain uniformity of co-interventions. Next slide, please. So the bottom line is it appears to be reasonably effective and safe to offer observation to a well-defined set of stable patients. But I will note that there was about 2,500 or 2,300 patients screened, but only about 316 that met criteria to be able to be randomized. A major strength is that this is a multi-center randomized study with reliable measurements. It's probably the best evidence we have so far. Most of the other evidence in this area is not as robust. They used both intention to treat and per protocol analyses, which replicated each other. The limitations are that the most important outcome is tension pneumothorax or death, and this study is not powered to answer that question. Their non-inferiority margin seems reasonable, but it does not appear to have been informed by patients, and in general, the patients are going to have to bear the cost of this. And it's unclear but the effect of having a low number of patients at each site, and in terms of the conclusions you can draw from that. And so that's it for me, and I really welcome the discussions.
Thanks, Dr. Kadani. That was excellent. Dr. Schellenberg, I'll turn it over to you if you could give us some comments on your thoughts on this paper.
Thank you so much, and thank you to Unitar and to EBRS for the opportunity to be here today. First of all, I would love to commend the study authors on undertaking such an interesting paper. I think it was a really well done study and certainly required a massive amount of effort to bring it through to publication. So congratulations to them on the paper. The first thing that I would say when I sort of read this paper and think about incorporating it into my clinical practice is, I think in calling the non-interventional group the conservative management group, I think it's a bit of a misnomer. And I think, what I would argue is that not placing a chest tube into these patients is potentially really the sort of aggressive management group. And what would be conservative would be to drain their pleural spaces. And to me, when I frame the clinical question in that way, that sort of sets up the rest of the paper and the rest of its interpretation for me. Really across a lot of surgical specialties now, I think we're looking at trying to do less to patients, but achieve the same outcomes in order to have fewer complications, but avoid bad outcomes in those patients. And I think the study authors did that. They showed that non-interventional management was non-inferior to chest tube placement. And they showed that it reduced complications and didn't result in obvious harm. But I think exactly like Dr. Kadani points out, I think that the study authors have not yet completely reassured us that harm will not come to these patients who are not receiving a chest tube. And I remain concerned that these patients are going to be at home sort of out of reach of physicians, out of reach of chest tube placement, and something bad will happen to them because they haven't had their chest tube managed in sort of the conventional way, or sorry, their pneumothorax managed in the conventional way. So yeah, I think this is a really important sort of step towards managing these pneumothoraces non-interventionally, but we need a sort of larger study moving forward to really reassure us that these patients will safely be managed conservatively.
Excellent, thank you. Dr. Ball, your thoughts on the paper?
I would echo Dr. Schellenberg's comments as well. Thank you for the opportunity to be on with everyone today and both groups for putting this together. I don't have a lot to add. I'll say I thought the design of the study was quite good. I particularly enjoyed the honesty in the limitations section by the authors. I think that's always a very hard paragraph to write. And to be succinct and honest and disclose really everything you're worried about. So hats off to them. Using the Collins equation to evaluate the size of a pneumothorax is interesting. It's a commonly used formula. It's simple. You can apply it across the world. But there certainly is other equations that are potentially more accurate. So I do worry a little bit about that. I'm certainly not surprised by the findings. You would expect probably folks that don't have the less aggressive intervention with the chest tube to have a shorter length of stay and probably less trouble and less surgery and back to work earlier. So that makes sense. As Dr. Kadani pointed out, it's very interesting to contemplate the physiology and the anatomy associated with these different recurrence rates in the two groups out to a year. A 17 versus a 9% difference is massive, quite honestly. I think that was a little bit surprising, at least to me, and thought a lot about why that is, and I'm not sure I have the answer at this point. But again, as Morgan pointed out, it's hard to follow these patients out to a year, and the authors did a great job of it. Maybe the last thing I'll mention is maybe a little more controversial. It's interesting to me that two of these patients were described as having tension pneumothoraces. And Dr. Kadani, as you just heard outlined the scenarios in both those patients. The reality is there's two very good physiologic and anatomical reviews published in the literature that really question the ability of a human being to develop a true clinical tension if they're spontaneously breathing. In other words, they usually have to be intubated on positive pressure. It is possible, but boy, is it a rare event. And often what folks are talking about is radiologic tensions, which for those of us that deal with a lot of pneumothoraces, we see not infrequently, and we're having normal conversations like we are today with these patients with huge radiologic shifts. So I do worry, or I do wonder a little bit about those two folks and the fidelity and the granularity with which they were diagnosed. But overall, I thought it was a superb approach to this question that really does have clinical equipoise.
Thanks, Dr. Ball. I think just from what you just said, I want to ask two questions. I'm going to follow up with one for you, Dr. Ball, and then one for Dr. Kadani. So one of the things that you mentioned in your commentary, which will be up on our EBRS website fairly shortly, is the limitations and how honest the authors were about the limitations. And the other thing that you mentioned was the statistical fragility. And I think that that's probably a big issue for us in the surgical literature, where we have smaller N values in our trials. Dr. Ball, can you comment on that? And afterwards, Dr. Kadani, one of the things that Dr. Ball just mentioned was really that difference in the recurrence rates, which was probably, I think, something that we all found surprising. 16.8% in the chest tube group versus 8.8% in the conservative management group. So if you could mention that or discuss that, that would be excellent.
I think thanks for the opportunity, Neil, to comment on that. You're exactly right. The authors fully disclosed the concept of data fragility in their trial. And I almost think that we should all be mentioning that with any randomized control surgical sort of study that we publish. It should be limitation number one, because as you point out, it's overly common. In Canada, as most of you know, we're very lucky to be loosely associated with, titans of evidence-based medicine like Gordon Gaillet, but one of his partners, Mohit Bandari, who we also, a lot of us are friendly with, is an orthopedic surgeon who, is well known internationally, not only in the New England Journal, but elsewhere, for doing global trials that almost always involve China and India with thousands of patients and very simple questions. And one of his best talks really is an hour surrounding this concept. And at the end of the day, it really does boil down to what's in your numerator and what's in your denominator. And when you see most of these surgical trials and you're lucky enough to review them maybe for a journal, the first thing I do is start moving patients from one numerator in ratio 1 over to the other group in the other, and see how many I have to move to change the author's conclusion. And it's shocking, both in terms of trials that, say, we've done as a group at the University of Calgary, and in what you review globally, 1 or 2 or 3 patients oftentimes changes your statistical outcome. And that's really the evidence, or the example of data fragility. So number 1, you're right, I think it's a limitation of surgical trials. Number 2, we need to disclose it each and every time. And in fact, I try and make an effort in the trials that I've been lucky enough to publish of actually putting that number in that paragraph. And then number 3, one of the questions you had asked me, quite honestly, was how do you create these really large trials in the era of fiscal responsibility? And I would point again back to Dr. Banderi's trials. They're not overly expensive. You can see in this particular study, there was 39 centers, as Dr. Kadani mentioned, involved. You leverage and you rely on relationships with colleagues and friends to get things done. But it's certainly a challenge with most surgical trials, you're right.
I agree with Dr. Ball on that. So to address your question about the unexpected finding of the recurrence rate, I think I probably would go back one step and say that this is not just slightly surprising and unexpected. I would say it's shockingly unexpected and surprising. In general, there's 2 approaches to this. One approach is to kind of engage in this exercise of post hoc rationalization and trying to make mechanistic justifications for a finding that you see. I would caution against that because, it flies in the face of what we understand about the disease process and what we've theorized, the proposed mechanisms, which may themselves be flawed, but I think that's where we're starting from. And I think this is a situation where a really Bayesian approach is really helpful because in reality, in life, truly shocking and unexpected results rarely occur. They're very rare. And so we have to understand what the prior probability of something happening is, and which will inform the posterior probability. So in a situation like this, where there's a shocking and surprising result, there has to be a higher threshold for accepting it as reality. And that's entirely the basis of the Bayesian approach. So in this situation, I think it's an interesting finding. I think that's something we can say is a somewhat hypothesis generating, but it is one of many, many secondary outcomes. The numbers, and this actually speaks a little bit to the fragility aspect. The more outcomes you have, the more and more fragile, the less expected, the lower the prior probability, even the greater the fragility in these kind of situations. So I would say that this is, in general, I find the results of this study, for the most part, highly credible. I find that one part highly incredible in both the colloquial and the literal meaning of the term.
Excellent, thanks. I'm going to ask Dr. Schellenberg to comment on a 2-part question. The first is that they screened a large number of patients and then they randomized a small number. Does that make you concerned about the external validity of the study and what the patient selection involved, or whether or not they were using other criteria that are hard to describe in the manuscript as to why there was such a difference in the number screened and the number included? And then the second part of that question, and I appreciate that you probably don't see a lot of these patients with spontaneous pneumothoraces, but if you do see someone like this, would your approach to them be different after having read this study? Thanks.
Yeah, that's a great question. I think that's, anytime we have new literature sort of contributing to our understanding of a problem, those are exactly the questions that come up. Who can these results be generalized to, and how are we going to change our practice sort of as a result? Absolutely, the fact that they started with a large population of patients and only randomized a small percentage of that, that always raises concerns about generalizability. So yes, absolutely, that raises some red flags for me. In terms of who I would, apply these results to, and which patients I would consider managing non-interventionally now, to my mind, the most important thing is rigorous patient selection for that role. I think because these patients are going to go home and need to self-monitor their symptoms very closely, I think only sort of mature, self-aware patients are candidates for this approach. I know the study enrolled patients 14 to 50, but someone might argue that teenagers maybe aren't ideally suited for this management approach. But I think a patient who is, highly motivated to avoid a chest tube, somebody who was alert enough to be able to detect subtle differences in their symptomatology at home, patients who are within easy reach of a hospital, and a hospital staffed with providers who can place a chest tube quickly. And I think people who are pretty sort of health literate, I think these patients will need to understand what we're trying to achieve with this management approach, and be able to sort of look out for the red flags themselves when they're at home. So again, I think that's actually pretty restrictive. I think there aren't a lot of patients who will satisfy all of those criteria, but if I had someone who did, I would have this discussion with them and discuss this sort of paper with them and do shared decision making about their management.
Yeah, that's a great answer. I agree with you, and I pose similar question to Dr. Ball. So I mean, a study like this, are the results really only useful in an urban setting where there's lots of proximity to healthcare, and there's good transportation, and are these applicable to, for example, rural and remote areas, or austere environments without a lot of resources? So getting a repeat chest x-ray is not something that you can just get in 5 minutes. Getting back to the hospital involves walking to the hospital as opposed to driving. Are these things that make this study not very applicable to these other environments, or how would you apply this study in these resource austere environments?
Yeah, great question, Elijah. At the end of the day, it's an important question because most of the healthcare on this planet is delivered, in non-tertiary, non-quaternary care facilities with that kind of healthcare system. So you're exactly right. I think the answer is no. For me as an individual clinician, my opinion would be that this manuscript does not provide enough of a level of confidence and security to allow me to sort of not ignore, but certainly change a practice based on decades of literature that tube thoracostomy is probably the way to go. It's a start down that path, and it may in fact be correct, but it might not be. And you're exactly right in your, the insinuation in your question that we can't necessarily apply all technology or all care uniformly across all patient populations. So I think you have to individualize it, and you have to pay close attention to all of those elements that you pointed out, and your ability to respond to a problem, whether it's a true tension or whether it's not, and make the best decision for the patient in front of you.
Thanks, Dr. Ball. I think I'll open up a question to all the panelists for their opinions. This study used chest x-ray to follow up on patients. And of course, we have attendees here from North America, Europe, Africa, all over, again, from different healthcare systems. Can you discuss the roles of CT versus ultrasound, particularly as point of care ultrasounds getting more prevalent, versus chest x-ray in following up these patients, and your thoughts on that? Maybe I'll turn it to Dr. Schellenberg first, and then all three of you.
Yeah, it's another great question. I think ultrasound is an incredible imaging modality. It's incredibly useful in a lot of settings, particularly for pneumothoraces. It's especially useful for sick patients. They don't need to leave their room, and it can be done quickly and by the clinical provider, which is all really useful. I think the very high sensitivity of ultrasound in detecting pneumothoraces potentially sort of hinders its role in this particular patient population, because you'll pick up a lot of tiny pneumothoraces with ultrasound, really ones that no one would place a chest tube into. And I think that for that reason, it would potentially sort of confuse interpretation here, because I think you diagnose a lot more pneumothoraces than need chest tubes, if that makes sense. So I think chest x-ray is the right sort of screening modality, although CT scans are particularly useful in these patients to look for apical blebs. I think since we're not considering surgical resection at the first presentation anyway, CT scan I think would sort of be overkill, so to speak.
Dr. Ball, Dr. Kadani?
Yeah, you know, if we take a step back and we look at the test performance of these studies for pneumothoraces specifically, you know, an upright chest x-ray typically in most scenarios is performance, you know, sensitivity over 90%. If you look at a supine chest x-ray, it's 50-50. So really quite poor. As Dr. Schellenberg points out, ultrasound, you know, it's been reported at 100% with a good operator in absence of subcutaneous emphysema, but and no test is perfect, but it's certainly up there, maybe overly sensitive. That's a great point. CT obviously is darn near perfect, but costly and not always accessible. The real question for me is, if you're going to start to talk about point of care ultrasound, you're talking about repeat ultrasound and repeat sensitivity rates. And we know that, for example, in hemothoraces, repeat ultrasound, whether it's on the ward or whether it's in an outpatient clinic, is not overly sensitive or overly good as a test. We've started to believe ultrasound's pretty darn good in terms of following residual pneumothoraces. But, you know, Dr. Schellenberg brings up a good point. Maybe it's overly sensitive. The reality is, you know, there's 17 different indirect signs of pneumothorax on an ultrasound. We really use 2 or 3 of them on a regular basis. You can use ultrasound to quantify volume. There's no doubt about it, but that's sort of a step up in terms of ultrasound talent or skills. And most people would not have that. So that's a very interesting point, but there's no question, you know, you can now get an ultrasound probe to plug into your smartphone for under $100 US. So folks are going to figure out a way to use that in many different applications. It's sort of the way forward, irrespective of whether we like that or not.
Yeah, I think I agree. The one thing I would perhaps mention is this is sort of fundamentally a frame shift in the way we approach this problem. So the discussions about test characteristics or performance of tests are actually related to what the result is. What are you testing, right? So in this particular situation, we're trying to do less with that first one. So having a test that has higher sensitivity, in fact, is an Achilles heel rather than you know, whatever the opposite of an Achilles heel is. But it's actually quite useful for the follow-up and what Dr. Dixon mentioned, meaning that when you're doing the serial x-rays, you're actually looking for resolution. And the sensitivity in that situation actually is quite helpful and useful. And so that may actually be where that modality fits in, is that you use the x-ray to define whether or not you are going to put the tube, because it allows you to see the bigger pneumothoraces, and then you use the ultrasound as a point of care way to, in a very easy resource, sort of, I guess, with that $100 option, a resource conscious way of monitoring these pneumothoraces for resolution.
Just to follow up on that, you know, in that conservative group, they were leaving hospital sooner, going back to work sooner. But I think the median time to radiographic resolution was double. It was 30 days versus 16 days. Does that matter? Dr. Kadani, I'll put it to you.
Again, I think it really depends on the person. I think to me it matters, but perhaps I could be accused of being a type A person that wants things resolved quickly. So I think it really does depend on people, and I really 100% agree with what Dr. Schellenberg said, that this is a real opportunity to have informed discussions with patients, to really tell them, you know, there's no right answer, really. In general, what this is telling us is there are pros and cons, and that it could be safe in a select situation, but there are costs, and the costs are not the monetary costs. The costs are the anxiety you have of having this thing that's not resolved, that this could happen to you at home, that the pain you feel might be the tension pneumothorax building, rather than having that peace of mind of having this tube knowing that you're safe. Because fundamentally, a tube thrower cost to me is an intervention for safety. So if the patient understands that and is okay, is willing to trade off peace of mind and quick resolution for avoiding a tube, I think in an appropriately informed patient, I think that's very reasonable.
Great. So we have a question here in the Q&A, and why don't I put it to you, Dr. Kidani, to start. Can you comment on the decision-making process between no chest tube and ambulatory management versus inpatient management? And then as a second part to the question, which would be my question to you, and sort of going along the lines of what Dr. Ball had talked about in terms of large trials that are simple, how would you put together a future trial that would look at this question and actually move the needle a bit more for us in terms of making us feel more comfortable with conservative management of these patients?
That's a tough question. I think maybe I'll take a stab at the first one, and then maybe it'll give us a chance to think about the second. My personal belief, and I will say that there is a lot of variation in practice, and the majority of these are actually managed by and large by emergency medicine, and in different settings have a very streamlined approach to these, such that, you know, thoracic surgeons will basically get them see the patients in their office after they've had a chest tube and a Heimlich valve placed as an outpatient. My personal belief is that all patients should be able to have outpatient management, that they should, if they get a tube placed or a pigtail catheter placed, they can be put on a Heimlich valve, a one-way valve, and be sent home. And in fact, the majority of them can be taught how to check for an air leak, so they don't have to come unnecessarily for x-rays and assessment to the hospital. So the precondition for removal is cessation of the air leak, not necessarily the x-ray. So they can be taught how to test it at home, and then they can come back. So I would say that nearly 100% should be able to do that. The second question, I have to say this is a very difficult study to pull off, and I think kudos for this group for being able to do it. I think the real, I don't know, I may not offer the exact solution, but I think I know what we should aim for. We need a much higher volume of patients, because we need to have enough event rate of the actually important event, which is a tension pneumothorax or death. But absent that, we really can't make any comment other than to say that this could be reasonable.
And any comment on what Dr. Ball had discussed in his original comments, the recent reviews on tension pneumothorax and how frequently they actually occur in terms of not radiologic appearance, but physiologic presentation?
Was that for me or?
Yes, for you, and then for you.
Yeah, I'm not sure what to make of those. I don't know. I have seen, again, you never want to rest on anecdotal evidence when there exists empiric evidence. And my concern is that I have seen quite dramatic shift without tension physiology, like radiographic shift, but I've also seen quite dramatic tension physiology in people that don't have as dramatic a radiographic picture. So, and there's immediate resolution as you expect of the tension physiology. So I would have to look at the studies a little more and get a little more replication. The unfortunate part in the human population is that it's hard to take him to the edge where it's not safe.
And in those patients that you saw, that were those spontaneously breathing patients or patients that were under positive pressure ventilation?
Yeah, they were spontaneously breathing patients, but and it's interesting. It's related to the actual size of the defect in the bleb or bulla. So when you see these patients, you know, often some of the paradigm in my mind is kind of shifting a little bit. That because of our uniportal VATS and approaches, and sometimes non-ventilated, spontaneous ventilated VATS operations. It's entirely reasonable to do a lot of these on first presentation when the pneumothorax is not resolving or the air leak is not resolving quickly. So we do see these patients with these huge tension phenomena like florid air leaks that don't stop, and you see there's these big holes in the bulla, and you know, I think those kind of patients are at high risk for developing the tension phenomena.
Go ahead, Neil.
I'll pose this to Dr. Schellenberg and Dr. Ball. Chest tubes aren't an inert procedure. And Dr. Ball, in the trauma literature, you've documented quite well that there can be a fairly high complication rate associated with chest tube insertion. I think both of you work in large centers with multiple trainees of different levels. Can you comment on the complications associated with chest tubes, how you managing that in your discussion with these patients?
Yeah, that's another really good question. I think in terms of the complications, I think what we're sort of willing to tolerate in terms of a complication rate, I think differs dramatically depending on the sort of urgency or emergency of that procedure. So when we're doing these chest tubes on the trauma side, I think we accept that that must be done very quickly, and that, for example, you might be making an opening into the pleura that's larger than you need, and then that patient's at risk for reaccumulation of the pneumothorax when you pull the chest tube, for example. So I think in sort of interpreting the complication rate, you have to consider what you're gaining from that chest tube insertion and sort of weigh those out. But this is, like anything we do in surgery, I think the trainees need to be appropriately educated and trained before they attempt that procedure on a patient, and they need to be appropriately supervised, through their first few. And as long as those things are being done appropriately, I think, in the vast majority of situations, you can have a safe chest tube insertion. That being said, particularly with the Seldinger chest tubes, there are absolutely risks to inserting those. I have seen people put the sort of introducer into the internal mammary. I've seen them place it right into the lung parenchyma. There are certainly risks. And I think if we can, as a community, accumulate enough evidence that reassures us that these patients can avoid the chest tube, that would be great for them. But I think in the meantime, sort of mitigating those complications with good education and training before people are placing these chest tubes into patients, I think that's sort of all we can do.
Yeah, I don't have a lot to add to that, Neil. I think that's perfect, Dr. Schellenberg. The chest tube complication or insertion rates of major complications are clearly different with small, nearly percutaneous tubes versus traditional 36 French tubes. But I do think in general we historically have blown off the chest tube insertion or tube thoracostomy as a simple, anybody can do it procedure, and I think the complication rates traditionally have reflected that. So I echo your comment that supervision and training and skill is still important.
But may I make perhaps a controversial and contrarian comment on that? So I would say that we have to think about two things with this study. One is that that the worst complications from the chest tube insertion actually occurred in people that had to cross over, meaning that they had to do it quick in reaction to something that's an uncontrolled situation. And the other piece about it is that there were basically 39 centers and there was about 8 patients per center. So it's a very rare event, and the likelihood is that there's a variety of people that had to do it, and there's not much people who are developing a lot of expertise. When you frame in the context of conservative non-intervention treatment for small pneumothoraces and you add on moderate to large, you have to think about, you know, take this process forward in your mind and what's going to happen to people's ability to actually perform these well. And as Dr. Schellenberg noted, you need the training, you need the ability to do it in a controlled situation to do it well and to do it better. So are we setting up a situation where there's less and less experience to insert these pigtail catheters in these kind of situations, and then we set up a situation when they do occur, they're just going to cause complications? So that's just, I think, something that we have to keep in mind about these unintended consequences of a management shift.
Great. I think that we're sort of at wrap-up time. So I want to thank, again, I want to thank Unitar, Jeff Ibbotson. I want to thank my co-moderator, Neil Data. And I especially want to thank the panelists, Dr. Schellenberg, Dr. Ball, Dr. Kadani, for a great discussion and for taking the time out today. Really appreciate that. I want to, again, direct everyone to visit the EBRS website. We'd love to have you there. I want to also acknowledge the funding for EBRS, which comes from the Canadian Association of General Surgeons and from Medtronic. And then I'm going to hand it over to Dr. Ibbotson, who is going to put up a final poll and then a survey and a link to the site where you can get CME points for participating today. So again, thanks everyone for taking part, and thanks for everyone that logged on. It was a great discussion.
Well, thank you, Elijah, and thank you to all the panelists. That was a great discussion, very, very interesting. And I'm just going to ask Julia to put up the final poll, and we'll just see, you sort of could see this question coming your way. Are you going to consider conservative management for primary spontaneous pneumothorax or not? So if we can get everyone to answer that and then submit, we'll put up the results quickly. But while we're waiting for everyone to answer and put up the questions, I would just like to say thank you to ERBS for this work. It really, for many of us surgeons, this is wonderful work to be able to have this kind of review on a regular basis of various topics. And I know for years now, I've really enjoyed it. So thank you again. Keep up the good work. Julia, do we have the, yeah, we'll just put up the results there. Oh, pretty close split. Very good. Do any of you want to comment on that? Does that surprise you, or are you expecting that? No one wants to say anything.
I expected it.
Okay, good, good. All right, well, the next thing I'd like to do is I would like Julia to put up on the chat line. So if you look into the chat box, there is a link for you to answer a survey on the session today. This is important for us as a group because in the process of doing these sessions, we want to continually improve. And we also want to be able to offer CME points, and this is part of the process as well. So please click on that link and then save that survey and fill it out. It's very quick, it doesn't take very much time. And then the next link that Julia is going to put up on the chat is to direct you to the website for the Global Surgery Foundation. And we want to be able to offer you CME points, but we do need your email and name. so that that can be populated into the CME certificate. And so even though there's many people who registered, not everybody was able to attend. Of course, those people able to attend can register for the CME points. So please save that link or open it up in your computer as you move forward and register for those points. So once again, thank you very much to all the panelists and for the interesting conversation. Really enjoyed it. Thank you to EBRS Online for your commitment to reviewing these papers and evaluating them with a critical eye. It really is helpful for all of us who are on the front lines and helping the patients on the front lines. And I really look forward to upcoming events. Keep posted with the websites, both EBRS and the Global Surgery Foundation, and we'll notify you as upcoming events come along. So from Geneva, Switzerland, and the United Nations Institute for Training and Research and Global Surgery Foundation, thank you very much. This session is now completed. Thank you, and keep safe. Goodbye.
Thank you.